Our third expert is Sir Peter Bell, and Peter's going to defend the position that best medical treatment is best for most asymptomatic cases. A best medical treatment enthusiast interprets CREST. Peter?
Thank you, Frank, for the invitation to come here. You've heard two biased speakers already, so I won't say too much about them, except to say that they're both wrong. I have no financial disclosures. This is the second person you heard speak, Wes Moore. Now, he's a nice chap. This is a picture of him shopping yesterday in 6th Avenue. He doesn't know who should not have an operation when patients have got no symptoms, so the best thing is to operate on all of them and hope for the best. Then we have William Gray, who is a man who thinks that if one stent is inserted, two will be even better, if possible, and has been known to say all sorts of silly things in the past, like 4.8% stroke rate in the CAPTURE trial was reasonable. And he thinks that minor strokes don't matter. It doesn't matter if you can't remember who you are, or whether you can do your fly-up or not, or whether you can actually point down the street. It doesn't matter at all. You can also be a radiologist, I suppose. Now, if this man approaches you, you've seen what it looks like, cover your stents, cover your groins, he'll stent you for sure. After the so-called CREST trial, we knew what it was all about because we had all of this sort of thing. Everyone should have one, whether they need one or not. All normal people should have one immediately because it was very valuable. And then we have this inexplicable FDA committee who must be, I don't know who they could be, but said everyone should have one now, even normal cases. Let's look at some of the things that we shouldn't be talking about here. According to CREST, in patients with no symptoms, the annual stroke rate for CEA was 0.9%. For CAS, it was 1.6% in these patients. Just remember those figures. If we look at some data from 2005, when 122,000 patients with no symptoms, a frightening number, was treated at a cost which would probably bail out the EU. And remember, the annual stroke rate now is about 0.5% on best medical treatment. Remember those figures? 0.9% in CREST, 1.6% if you use CAS. This means that in 2005, and it's probably worse now, with medical treatment alone, you would get 615 strokes approximately. Then minor ones, of course, don't matter. You can't walk or whatever. With CEA, you get 1,107 strokes. With CAS alone for all these patients, you get 1,968 strokes. Rough figures. These results are from trials where the operators, as Wes Moore said, are the so-called best. Imagine what will happen when the rest get let loose. It'll be absolute bloody carnage, won't it? So, according to the CREST data, CEA will cause 492 extra strokes. And that's Wes Moore in drag. And according to the CREST data, CAS will cause 1,353 extra strokes, and that's you-know-who in drag, every year. So here we have these staggering numbers are a waste of money at best and unethical at worst. Old Hippocrates will turn to his grave for all sorts of reasons. So who in their right mind can recommend invasive treatment for this condition? Here's one chap who's thinking about it, listening to evidence from both sides and ignoring it completely. And here's the other chap who looks remarkably like Hippocrates, doesn't he? But he's different in many ways, as we've already discussed. So the conclusions from this it must be, I'm sorry to insult your intelligence, but I have to tell you anyway, that the CREST data indicates a 30-day stroke and death rate of 0.9% in patients with no symptoms who have CEA, and 1.6% in those treated by CAS. Best medical treatment, 0.5% per annum. It's a no-brainer, is it? Invasive treatment is actually causing unnecessary strokes. and there's no indication whatsoever to treat the vast majority of these patients with any invasive procedure. No one disagrees that some people will have a stroke, and we should spend much more time trying to find out who they are, using TCD, plaque morphology, diffusion-weighted MRI. There are ways of doing it, but we shouldn't treat the whole lot just in case. Thank you.